Thank you and good morning, and thank you for inviting me to talk at this social marketing conference. I'm from public health, but I've been involved in mass media campaign design, development and evaluation for over 30 years, which has intersected with social marketing in part, and that's partly what I'm going to be talking about today. My title of my talk is about politics and promotion, but I'm going to work out how to get to the next slide. Having solved that hurdle, I'm going to give you some thinking from public health for the next 40 minutes or so. Firstly, I'll start with some definitional dilemmas about how we in public health and you in social marketing define things. Then I'll introduce you to the fifth P, the one you don't know. You're very familiar with the first four, and I won't restate them. I'm going to talk about a crowded house of messaging and branding in one particular area, and how in Australia we live in a very variegated and overfull health social marketing environment. If I have time, I'll talk about theory testing tribulations in a more complex piece of alliterative research. And finally, just to conclude the alliterative theme, I'll talk about the challenge of confrontation and what we can do in health and learn from your social marketing expertise. If we start with a definitional dilemma, and I give you yet another definition, you will have seen them all before. So I'm going to start by definition saying we'll only get tied up by spending much academic and practitioner time focusing on redefining things. Even when we lay out the principles carefully, we can't agree on definitions of what we do. And even when we provide rules and frameworks, it's hard to define what we do. So I'm not going to talk about definitions. I'm going to talk about wicked problems. And public health, which is my discipline, is full of wicked problems. Now, wicked problems are huge horrors beyond understanding, things that are unsolvable, things that ruin the world, and a wicked problem in public health is things that have complex causation. They have complex causation with no single response will solve them. No single strategy will solve the globalization of tobacco, will solve illicit substance use immediately, will solve binge drinking or obesity or physical inactivity, or will solve inequalities in access to preventive services. So all of those things are wicked problems. And we have to think, what's the role of social marketing, of mass media campaigns in contributing to solving wicked problems, not a solution in themselves? And that's a slightly different perspective in public health. We use it as part of a solution, not as the solution itself. And that's an important definitional issue. I'll take you back to show you a simple model of what causes obesity. It's very, very simple. And it's the Foresight report from 2007. Which started in its fundamental recommendations to the UK government that suggested that evidence from social marketing suggests it's unlikely that public information campaigns alone that urge people to eat healthy and move more are going to solve the problem of obesity. Complex interventions are needed beyond and building on information campaigns to achieve behavior change. And achieving behavior change is complex, although the factors underlying obesity are well known. And the Foresight report spent 2 years modeling the causes of obesity. And you can see here they include social influences, individual psychology, the food environment over on one side, and the physical activity, inactivity environment on the other. And when you put all those influences together, a simple model emerges of how to change obesity. And the full model, so that we know what to do to address obesity, looks like that. And this is actually building the full model. And no piece of marketing, intervention, regulation, or policy can fix that. But we can take some parts of social psychology, individual psychology, active environments, food marketing, and build messages around awareness, understanding, changing community norms in those areas. And that's what we try to do in public health. To change complex population health-related behavior requires multiple actions, multiple interventions. complex public health programs. It's easier to change with marketing if it's a single behavior. Get your children immunized is mostly easy. Attend screening is mostly easy. Many people in target populations who need to have screening do so. Single behaviors, adherence to preventive actions once you've got people doing something. But it's more difficult to influence the societal, globally defined behaviors such as what we eat, how much we move, drinking and smoking. Those kinds of things are much more complex. Is this new thinking in public health, this idea of multiple interventions at multiple levels required to solve wicked problems? It's not new. This cross-sectoral approach to complex problems was in the Ottawa Charter for Health Promotion in 1986. Yes, 1986, when some of you in the audience may not even have been very old. In other words, this has been around for a long time as a way we should be doing things. And in public health, we're very good at knowing what we should do and much less good at implementing the full model of what we're trying to do. What's the history of mass media and social marketing in Australia? And these are my personal perspectives because I think I was around relatively close to the beginning. They're usually government or non-government organisation run information or awareness-raising campaigns targeting whole populations, or they were in the 1980s. They developed out of a collaboration between public health people and persuasive mass communications experts, particularly in Stanford, but in other parts in the 1970s onwards. And they built on a range of community-wide prevention programs for heart disease in three sites in North America, in Finland, and in the UK. Some of the early campaigns I was involved in was the development of the Quit campaign, the first anti-tobacco campaign in New South Wales in 83 to 85, evaluating the sun protection campaigns of the early 1980s. And I came into public health just at the tail end of the still recalled, even by people who weren't born then, Life Be In It campaign, modeling Norm, the man sitting on the couch, modeling Norm, but a lot of people might have identified with him as socially normative to be sitting on the couch watching television. Life Be In It, contrary to the views of Brian Dixon, the MLA from Victoria who was involved in it, was never evaluated at the time. So we never know whether it was a positive or a negative force. Okay, now the next few slides are very old. Some of them are as old as the Ottawa Charter, but it defines how we think about mass media campaigns, or how I started to think about them a long, long time ago. And a campaign had to be multifaceted because the Ottawa Charter said that's how we made change for wicked problems. So there was media, and in particular the media had a strong communications element, and it was mostly paid and sometimes unpaid with community service announcements, with media advocacy and with ancillary strategies. But for a media campaign to work in public health, we said then that it had to have environment and policy supports. It had to have professional capacity building and professional education and engagement so that you got primary health care, you got sport and rec, you got school teachers, you got the education system. Whoever was needed was also part of the campaign. It involved community programs being delivered to support the campaign, and concomitant and synchronous with it, not some other year or some other time, which is what usually happened in public health and perhaps still does, as I'll show you. And perhaps that's even a contemporary model, with the only thing I'd add in this century is the huge rise of social media and its ancillary roles. And everything else I think that we wrote in the late 1980s still holds for what we should do in public health. And what we said mass media campaigns should do is increase understanding or awareness of a specific health issue, help form beliefs, make them more salient to people, personally relevant to them around an issue, get people talking to each other, get people to initiate information seeking or self-directed behaviors towards making changes, identify the need for change and a way of doing that, and perhaps change individual behaviors. One model suggests that there are many ways that media might assert their effects. The direct effects model, the media will get you to call a quick line or call a helpline, is one model, but the indirect effects is the media will set the agenda for change, and you need public discussion and policy infrastructure and facilities to help make those things happen. Another approach, which is much older and one of the oldest theories I can find in how human behavior works, is the hierarchy of effects model. This model is not popular amongst social marketing academics. It's considered outdated, and I'll show you some interesting hierarchy of effects data later if time permit. But it says of your target audience, if you run a campaign, if half are exposed, only half of those will change their, will attend to it, half of those will understand it, half of those will see it as personally relevant. And the actual likelihood of behavior change is way down the end of small probabilities, perhaps less than 1% of the original target market. We deal in population-sized target markets, so it might be the whole population, or it might be all women, or it might be all males 60 years and older, but it's still millions of people, so our target markets are big. And we propose that many of our initiatives will result in a causal chain with a low probability of behavior change. This kind of causal change from awareness through to behavior we can think about as proximal variables, intermediate things, and endpoints in conceptualizing how media campaigns might work. Most of the reviews of mass media campaigns show that that's what they do. They change awareness and knowledge, and fewer change attitudes and behaviors, or even measure them seriously as primary goals. What makes a good mass media campaign? The World Health Organization put together a consultation on obesity in 1998 and produced a document called Successful Features of Mass Media Campaigns. Fascinating document because it was developed by an obesity prevention group, and at that time there had been no obesity campaign, so their evidence base was limited. It was developed by a group with limited media expertise in the panel, but they mostly got it right. And what they said was, the effective features of the campaigns down in green and mass media practice in the right. You need adequacy, duration, and persistence. It's no good having a one-off campaign. You need to keep on reminding people. And we've seen people in November, they've forgotten last year's sun protection campaigns. In Australia, we re-remind them, and they forget again, and we re-remind them, and there's a sawtooth pattern. And that's because the salience of the issue can be seasonal in the case of sun protection behaviors, but people forget. If you stop doing a campaign, behaviors will relapse at the population level. HIV in at-risk populations is an example of that. Grim Reaper was very successful, but its effect was not forever. You need serial repeated campaigns. You need to support campaigns with legislative action, environment and policy supports, education, and shared roles of community agencies, non-government organizations, and other agencies. This is remarkably prescient. It also sounds quite a lot like social marketing. It also doesn't sound quite a lot like most of what we do in mass media campaigns in health, but it sounds a lot like social marketing. So we're talking the social marketing talk whilst walking the mass media campaign walk. How does this lend itself to our definitional dilemma, which I started with at the beginning? First of all, social marketing behavior change requires education, communications and persuasion, and enforcement and regulation. Our mass media campaigns start with persuasion, a hierarchy of outcomes, a whole population, but target population if needed, and a needs assessment. We always do that. We do our formative research in very similar ways. The social marketing perspective is premised on a voluntary exchange. That's a little bit more specific than our persuasion. On a strong behavior change focus, we don't take that for the reasons I've described. Sometimes it happens. Audience segmentation, we often go for the whole population approach. And consumer formative research we do in similar ways. But further, your social marketing, education, communication, regulation, and environmental change has been around for a long time. Are our theories mostly mass media in campaigns? Well, it's better if it's an integrated campaign, and it's even better if it follows the Ottawa Charter principles, which suggest more integration. But in the textbook of mass media campaigns, Bill Paisley in 1989 suggested that mass media campaigns should be comprised of education, engineering, and enforcement. Sounds a lot like social marketing to me. Hence, we operate in this tangled and hybridized web, the interrelated web of mass media campaigns and social marketing. There have been major increases in the use of the term social marketing across the literature in recent years. Around a third, though, of health-related social marketing campaigns only use mass media communications. So they're actually traditional mass media. Social marketing is a brand or a label we use inappropriately in health now to describe what we do. Governments love the term, it sounds good. Health-related social marketing doesn't always target behavior change or voluntary exchange, nor do we always focus on an audience segment. And conversely, some things that are labeled mass media campaigns are clearly social marketing. So I did a bibliometric analysis of published studies looking at social marketing over a 2-year period to give me a sample size of 184, and mass media and campaign at all time. And just these are independent proportions, but the health focus is much stronger, is much higher in the mass media campaign area than it is in the 50% of social marketing efforts have a health focus. Chronic disease prevention is again significantly higher in this typology than in the social marketing one. So is population-wide. The typology is higher, but community and small-scale interventions didn't differ. In social marketing, you do a little bit more correlates or qualitative or thematic or formative research than those labeled mass media campaigns. And there's a lot of conceptual work, systematic reviews, and other theoretical models written in papers that are kind of a content without content. But I looked at the different discipline ways of defining what we do, just by citations, and Sandra Jones, Jeff French, Craig Lefay are very high in the social marketing group. And I'm a bit lonely in the mass media and campaign group, or rather, both of me are. I'll introduce you to the 5th P. You all know the 4 Ps, and this is the 5th P. The 5th P is politics. And politics is not Australian political campaigning, you know, dealing with boat people and refugees and Gough Whitlam and those kinds of things. The 5th P is the political influence on health-related campaign content and timing. The first piece is the government priorities are what we do in run campaigns in public health. We have an obesity epidemic, so we run obesity campaigns. We don't have an inequalities epidemic. The second is that government ideology defines the way we portray the prevention message. The message continuum from individual choice, which is an individual responsibility, conservative ideology, a middle way, which might be nudge or liberal paternalism, to a social and structural determinants, which is often critiqued as the nanny state, and which governments we have in power can change campaigns in mid-course. The Change for Life campaign underwent such a change in the UK when government ideology changed. And occasionally there may be overt political campaigns which use health, run media-only campaigns that have no formative research, that have no partnerships with academics or jurisdictions, that are jingoistic and use health for government marketing and aim to increase the political capital and market reputation of health. I'll show you one now, but it's an old one, and it's an old one that I'm going to use because anything more recent might upset current policymakers. This is a physical activity campaign called Fit 2000 that was run transiently in 2000, just before a state election in New South Wales, and looks and feels like a physical activity campaign.
The days can pass you by. Well, time can pass you by in
Of course, there was no number to call. It was 2 weeks before the state election. A similar process happened in Queensland 3 years before using Greg Norman in an equally jingoistic campaign. And the state government that mounted that campaign lost the election. So it didn't work. But careful marketing. It looks like a physical activity campaign. It feels like a feel-good campaign to motivate you to be more active. It's got population diversity. It's got behavioural modelling. Here's another example. Commonwealth Department of Health, the Red Chair campaign that was part of the National Get Moving campaign. This was all that there was of the Get Moving campaign, and it was supposed to be part of a $6 million investment in obesity prevention for kids.
For an hour or more a day. And for more info, go to healthyactive.gov.au.
It's the right message, it's well crafted if it leads to something else. But what we sometimes do in health is we run this without any of the other features to build on them. Marketing Walk to Work Day, the Pedestrian Council in 2003. This is a credible role model who walked every day, our then Prime Minister. Is it also political capital? But there are some campaigns that show better integration, sustainability and cross-sectoral partnerships. We had one called Active Australia in the late 90s, early 2000s that was New South Wales-led, demonstrated clear effects of the campaign, and the fact of doing the research led all the other states to want it, and it became a national strategy with cross-sectoral partnership. Similarly, in Western Australia, the Find 30 campaign has been led through a Premier's Department cross-government 11-year initiative which lasted until 2012. But we live in a crowded house of messaging. I'm going to show you everyone has to have a campaign. Everyone needs to have a campaign in the space, and everyone's pushing to have a campaign. And we've also got the private sector marketing of unhealth in the obesity area to complement and contradict what we're doing. Now, we have 8 countries in Australia, 7 states and territories under federal jurisdiction, and they all operate independently of each other in campaign development. For obesity-related social marketing, we've had national campaigns recently, completely unrelated state-based campaigns in Victoria, Western Australia, and Get Healthy in New South Wales, and partly unrelated non-government organisation campaigns around sugary drinks. Different messages, different themes, different brands, different taglines, all at the same time. And I'll show you how different they are. This is the Rethink Sugary Drinks campaign of the Cancer Council, Heart Foundation, and Diabetes Australia, which is a great message built on a Bloomberg message from New York. It's an advocacy campaign. It's trying to get policymakers in the community to think about an advocacy issue. That's quite different to the federal government's 2 phases of campaigns, the first of which was about measuring your waste, and the second of which was about nudge or small changes. The first part of the national campaign, the Measure Up campaign...
Life's so busy, you don't even notice how much unhealthy stuff you eat or how inactive you've become. From today, I'm going to turn my life around.
It's never too late to start taking steps.
I'm going to start by finding time for walking.
Aim for 30 minutes or more physical activity every day.
And by eating better, I've actually started feeling better.
2 serves of fruit and 5 serves of vegetables a day can improve your health. What measures will you take? Go to australia.gov.au/measureup, authorised by the Australian Government, Canberra.
And just when your mindset is thinking about measuring and lifestyle change, the next phase of the national campaign introduces Eric.
I've been losing my belly, but I haven't been losing all the things I love, because I've become a swapper. I've been swapping big for small, swapping sitting for moving, swapping watching for playing.
Here you go, Eric.
And swapping often for sometimes. Once I got into it, I found it was easy.
To help lose centimetres without losing out, you don't have to stop it, just swap it. So start swapping today. For more tips, visit australia.gov.au/swap it. Authorised by the Australian Government, Canberra.
And then at the same time, two large states, Western Australia and Victoria, were developing a fear-arousing message. A completely different frame comes from the kind of very good tobacco work that emanated from Victoria, called the Live Lighter campaign.
When you eat more than you need to, toxic fat builds up around your vital organs, bringing heart disease, diabetes and cancer closer. Fat around your waist is bad, but toxic fat around your vital organs is worse.
But in New South Wales, we were using mass media to drive people to an obesity prevention telephone service called the Get Healthy service. What we found was when we bought TARPs, when we bought media, people were driven to call the Get Healthy service. All other strategies through general practice, through public health units, through community marketing didn't work, and the mass media campaign for obesity was used to drive people to get healthy. So you can see it's a crowded space. It's a complex space, and it's difficult to disentangle the cognitive profile of what to do with multiple messages for the community around obesity prevention. Quickly, to deal with theory testing tribulations, just a very small piece of some of the kinds of research I like to do. And social marketing is premised on theory testing, but it's difficult for us to do that in population campaign evaluation studies. It's easier if it's panel data, cohort data, where we've got the same people that we can track. One research aim might be to assess the hierarchy of effects. Does it work? The relationships between exposure, awareness, attitudes, intention, and behaviors. But it's almost never empirically tested in health. If you do a review of hierarchy of effects in health, you'll find less than 3 published examples of it. So we thought we'd test it in physical activity. So we tested it in the VERB campaign in kids in the US. And the VERB campaign was a huge funded mass media-led physical activity campaign in the US, a media budget of $250 million over 3 years, targeting 9 to 12-year-olds. And we tested the hierarchy of effects model. Did it work in kids? Testing it specifically. So we tested it very linearly, and we found that, first of all, awareness led directly to understanding in kids, a strong coefficient in our structural equation model. All the other things, awareness going to attitudes and expectancies, didn't happen, but understanding went significantly straight to the behavior. So once kids get the idea, they do it. They don't go through all the cognitive processing. And that's interesting to observe. So we repeated this in the Wheeling, West Virginia campaign on walking for middle-aged 50 to 65-year-old adults, where we wanted to test the same hierarchy of effects using a cohort design to see what it looked like. And we tested the same typical hierarchy of effects behaviors to see how the model fitted the data in that space. And what we found is that you can see exposure, all these red ones are all significant, led to attitudes with 0.29. Attitudes led to control, social norms and expectancy, and they all led to intention significantly. So there was clear examples of a more logical, significant hierarchy of effects, and intention at time 2 led to intention at time 4, which was significant, and intention at time 4 led to physical activity behavior. So adults went through a process almost exactly as the hierarchy of effects had predicted, and kids completely didn't. This is the kind of theory testing that we're trying to do to learn from your interest in social marketing theories and to test them better. Works well for adults and less well for American kids. Perhaps there are different cognitive pathways in kids, and we need to think about that. And we need to test theories rather than just dismiss them or accept them. They're used a lot in planning health-related mass media campaigns. We need to test them more. My last thought in this talk, and I'm going to wind up in a couple of minutes, is something I think we in public health can learn a lot from social marketing about. And it's an area of grave concern to public health at the moment, but it's a personal perspective. We need to learn about counter-marketing. We especially need to target what the Director General of the World Health Organization, Margaret Chan, described as big food, big soda, and alcohol-related marketing. And we need to work out how we can deal with and address their marketing strategies. Now, their marketing strategies are often to distract the issue. Coca-Cola running an obesity prevention campaign under the guise of physical activity, McDonald's sponsoring kids' sport and sponsoring healthy meal choices, but still perhaps making increments in their sales in unhealthy choices. The huge and pervasive way in which alcohol advertising pervades sport in Australia, particularly cricket and most codes of football, and that creates modelling opportunities for kids to associate those two. We in public health want to tackle that problem as a challenge. And how can we develop counter-marketing with wide population reach? We can do media advocacy, and we do. We need to learn about running counter-campaigns through social marketing. We need to learn how to do viral counter-marketing campaigns, how to work with non-government organizations, and how can we develop the coalitions that will run these campaigns to scale. The government's not going to fund us for $2 million to run this like a typical campaign, so where do the resources come from? And that's a challenge that we can learn from social marketing in. So to conclude, each of my points in order, we have definitional dilemmas. We shouldn't worry about them too much because we can spend our academic lives trying to define them. As long as we define what we do, we can see there's much overlap between what we'd like to do in public health and what social marketing espouses. Second, the fifth P should never be ignored in the work that we do. In small controlled studies of social marketing interventions, it's not an issue. In my day-to-day work in dealing with government, with NGOs, and with population-level things, politics can play a big role. We have a crowded house of messaging, not only on obesity, but on many other areas. That may confuse and disorient the public. Lack of taglines, lack of unified brand themes are limitations to what we're trying to do in public health. If you want to reject a theory like hierarchy of effects, please empirically test it first. And in starting to test it, we can start to understand these things better and know where and when and for which behaviors this kind of modeling is useful. And finally, counter-marketing may be a good use for social marketing skills, and we welcome that kind of collaboration in that challenge that's much greater and much less funded than a lot of the work we do in public health. Thank you very much.
Okay, so we've got a few minutes for questions. Down the back at the end. See
Craig, yeah.
Craig, just couldn't see the face.
Hey, Andrew, thanks very much for a lot of stimulating ideas there. I've got 2 points, 1 point and a question for you. First, with counter-marketing, in the marketing world, we're using demarketing to talk about those things. You might remember counter-marketing campaigns for tobacco, which were how do we make fun of advertising, which were found to be relatively ineffective and pretty silly. But the idea of how do we demarket big soda, alcohol, and so forth by focusing on the 4 Ps and using the 4 Ps to actually decrease consumption, I think is the idea that I'd like us to kind of take forward with this as well. But with mass media campaigns, you mentioned social media. And I'd like to kind of get your perspective on that. When I first started looking at social media, I started thinking about, wow, here's the time that we can finally start scaling up word of mouth communications. And as you know, mass communications relative to a word-of-mouth campaign is far less effective. Word of mouth probably the most persuasive way we can do things. And I'm wondering what your thoughts are now about this explosion of social media, and what can the communications world tell us about word-of-mouth marketing and changing behavior that might be applicable in that environment?
Social media has speed, it has velocity, and it has reach. It's almost instantaneous. It also has an attribute of something like transience. So that's a downside, if you like. What campaigns are now having, even government ones, are websites, platforms, and social media, if harnessed well and creatively, will measure the impact that that adds to and the effects that that have on traditional mass media campaigns. And that's a whole new area for research. We don't know. The potential is great, but the potential is maybe also overestimated as social marketing moves on to the next issue. And we want them to stay there. We want them to stay with the issue for at least 4-6 weeks. That's phase one of a campaign, and the next season and the next year. And social media has moved on and on since then. So it's a complex space, and we need to research it very carefully, quantitatively and qualitatively in this generation of what we're trying to do.
Hi, I have a question related to, with politicians, they're not just looking at health, they're looking at economics and a whole range of other things. So I think there's another conflict of interest there with the big business, because they bring in money to the economy, yet what they're bringing in is, affecting our health and costing the government money. So I noticed with the tobacco industry, it wasn't until they got kicked out of the agenda that we were able to do something about smoking. So do you have any thoughts around that?
There's trade-offs all the time in how much a government will put into public good or social good versus material good. I mean, the most efficient thing to do with smoking, in government terms, would be not to restrict smoking, let people smoke, because they die earlier and they save the system a lot of money in terms of health costs, because they die soon, quicker and faster. That's a completely untenable position from public health, and the same kinds of issues relate to our burden down the track versus what governments will do now. It's a complex area to work in, and governments have different responses to this across the continuum of messaging and political ideology.
Right, and our last question, just here. Thank you. I value your thoughts on the demand and supply. I'm a public health professional, and I'm giving an example of non-communicable diseases. You hype up in rural areas and urban areas, and people become so aware. And what is the supply situation then for them? They are so aware, they want to practice, but then they do not have anything.
That's the fundamental bottom line message of my whole talk. Where we've got mass media alone without on-the-ground services and delivery of nicotine replacement therapy or access to physical activity or healthy foods, where we fail to deliver the services, mass media alone is highly likely to be ineffective. And we knew that in the Foresight report, and we've known it for 30 years. So thank you for your comment.